anterior. We're going to switch to some complications. We'll talk about anterior vertebral artery exposure control options. Again, these are my disclosures. I think there's probably 3 keys when you're managing vertebral artery issues, whether it's anterior or posterior. And it's planning, preparation, and then practice. So planning, we'll talk about how we assess patients beforehand. Preparation means how do you get yourself, your OR, your team ready for a catastrophic event so that you're not shocked, surprised when they happen. And 3 is practice. And again, that leads us into the lab tomorrow. You're going to have an opportunity to practice exposing, identifying the vertebral artery across multiple segments, anterior, posterior, and both, and combined, that you will not have that opportunity in your patients unless and until you run into trouble. So planning, preparation, and practice. So when it comes to vertebral artery injury, we know that they come in different flavors. The most common cause, we think about trauma a lot, obviously, as that last picture had shown. But we also think about, and we want to talk today about iatrogenic injuries, right? So when we talk about the anterior-based vertebral artery injuries, they're almost always in that V2 segment, right? Below C2 in that foramen transversarium. I think the next talk is going to talk about posterior management, so we'll cover maybe some of the V3 injuries. Again, generally you're going to see an injury in this situation iatrogenically either from the dissection itself, from the high-speed burr, as we've talked about. You can see it from curettes, you can see it from Kerrisons, or you may even see it from the instrumentation if you're placing instrumentation, asymmetrically. The incidence is a tough one to get your hands on. It's reported somewhere as a fraction of a percent, so 0.3 to 0.5%. Higher in certain situations. We know that they're more common in trauma, where you have disruption of normal anatomy, more common in tumor cases, more common in revision cases. Again, all where you have disruption of normal anatomy. And we also know that most of the literature is going to underreport the actual percentages. And the implications of a vertebral artery can vary substantially, right? It can be obviously the acute blood loss and the local control that's needed, but also the potential for neurological injury, depending upon dominance and the status of the posterior circle. Worst case scenario would be a substantial or a severe vertebral basilar stroke. I've seen this only one time in my career, but it was devastating for that patient. Mortality rates in this situation are super high, and really the impact is a profound neurological dysfunction that does not, at least the patient that I had seen, did not reverse itself, with substantial visual field loss, hemiplegia, gaze disturbances, dysphagia, you name it. We pretty much hit every single one in that patient. Why does it come up with an anterior approach? Well, remember, we talked earlier about, I think Brian had talked about the need to be wide on your exposures, right? And I think in the lab tomorrow, we're going to talk a lot about getting wide on your exposures, seeing the uncovertebral joints on both sides, getting lateral to the uncovertebral joint. The most common mistake we'll see, right, in anterior cervical spine surgery is an incomplete decompression. And the most common reason for that is that you have an incomplete exposure. So we want to really press for a wide exposure. We need a thorough discectomy. You want a thorough and symmetric and central decompression. But that puts us right in the corridor of and right in the neighborhood of the vertebral artery on both sides. And again, I found this to be a really helpful image when we're talking about the anatomy of the cervical neural foramen, and to understand that relationship, that really close relationship between the uncinate, the vertebral artery, and then the nerve, the exiting nerve root as well. And we're going to work on that in the lab tomorrow. Tomorrow you should see this again and again and again and really let it sink home. This was a slide that's been passed along over the years. I actually don't know where it originates. I'm curious if someone does know where this came from. But it's a really wonderful anatomic cross-section, again, of a spondylotic segment showing that relationship between the uncinate. And really critically, it's that posterior corner of the uncinate, the exiting nerve root, and then the vertebral artery. And you can even see some of those perineural epidural veins that we'll run into when doing a wide decompression. So it's a really nice thought process to have around what's the relationship between these structures and why do we think about the vertebral artery so much from a standpoint of
that's such a great picture.
It really is. Where does it come from?
I don't know, but I can just tell you.
Rashni, okay.
But I can tell you, you
So
start
from
getting a bunch
Germany.
of venous bleeding as you're going out through that thing.
Yep.
That always to me is,
Yep.
we've done enough.
It's
That's
these right here.
Exactly right due to that.
It's these
such a great
right
picture.
here, right? But it tells you that you're at the you're by the dorsal root ganglion, right? When you get out far enough and you get out lateral enough. But that's a beautiful picture. So that came from Germany. Okay. So again, the relationship of the vertebral artery to the uncinate to the vertebral body has been pretty well reported. Remember, it sits in about the middle third of the body from anterior to posterior, or from ventral to dorsal. And again, it's just lateral to the uncovertebral joint, anywhere from 3.5 millimeters what's been reported, but it can be a lot closer than that. And there's quite a lot of variance. So our best way to prepare for this is to try to look for the vertebral artery on our preoperative imaging. Okay, look for anomalous imaging on your anomalous vertebral artery patterns on your MRI scan. You're going to very commonly have an MRI, and if you see something that doesn't quite look right, or you see an abnormal placement or positioning of the vertebral artery, you should think about getting an angiogram, get further testing, MRA or a CT angiogram. That's what I get in my practice. But you'll see examples throughout the literature demonstrating variances in vertebral artery anatomy in the subaxial spine. It's probably even more variable in the upper cervical spine. But somewhere around 3% of folks will have an anomalous vertebral artery. You'll see examples of dilated vertebral arteries, asymmetric, intraosseous, extraosseous, intradiscal. You can find, if it can happen, it's probably been reported. These are just a couple of examples of a dorsally located vertebral artery, so one that is sitting maybe a little bit more posterior than you would expect, okay, right in the foramen. And this is another example of a more ventrally located vertebral artery that's sitting, sorry if you will, up here, anterior to C6, and really running along the entire course anterior to where you'd expect it to be, okay? So look. And again, I think with preparation, somebody mentioned earlier about double checking. We always double check the vertebral arteries. It's really easy to conceptualize and get this mental map of an ACDF as quote unquote just an ACDF, especially when we do a lot more complex procedures from a standpoint of instrumentation, a standpoint of exposure, a standpoint of neurological decompression. And I think that's a mental trap that you got to avoid. And the only way to do that is to actively be thinking about it. And then I would also suggest communicate it, right? So talk with, for us that are in educational institutions, we have a chance to reinforce that with our residents, our fellows, right? But if you're in practice, talk to your PA about it and get your PA or APN into a habit of looking at the vertebral arteries with you. It'll keep yourself honest. And then you want to start planning for these catastrophic situations. So when you get a vertebral artery injury is not when you're going to say, okay, how am I going to fix this? Okay? And I think we'll have a lot of discussion around everybody's different techniques for how to stabilize and how to control it. But just a brief framework. Remember, with vertebral artery injuries, you're going to get rapid and immense bleeding. It is, while we do get those venous bleeders from around the nerve, and they always make me worry a little bit, but that's nothing compared to a vertebral artery injury and the bleed that comes with it. 3 things we want to think about, and I'll jump into each one in a little bit more detail. 1 is visualization and control. 2nd is clear communication. You got to communicate this with everybody around you. Call for help when you need it. And 3 is to lay out a strategy for when do you repair, when do you ligate, how do you make these decisions. So in terms of control, again, I think you want to place and hold. You can use cottonoids. You can use oxidized cellulose. You do not want to use FlowSeal or flowable products. I think you worry about pushing that into the circulatory system and creating downstream effects in terms of stroke from it. I don't know if that's actually ever been reported, but that's something that's been hammered in to me. You've seen it, Chris?
I've seen your partners hit the vert and basically put a thing of injector FlowSeal in and whoop, filled it up. Vertebral artery.
Stop bleeding. Yeah.
Okay. And so something they started, why I was called into the room was they started losing all their
signals. There you go.
And it turned up they had a massive Wallenberg stroke from that.
Yeah.
And so
no flowables, no flowables. Yeah.
Yeah. Surge a cell.
Surge a cell.
Surge a cell.
Yeah. That's oxidized cellulose. So pack and hold pressure. That's okay. You can use whatever brand, but other companies make it. Just pack and hold pressure, right? And it may be that you get your assistant to pack and hold pressure while you're doing the next steps. But you got to pack and hold pressure. Visualization is the next key thing then, and I again encourage you to do this in the lab tomorrow. Expose laterally, way more laterally than you normally would. Remember where the transverse process, you hear these called costal processes are. unroof the foramen transversarium. You can usually do that with a Kerrison or even a back-angled curette. The bone's not too strong, so it's pretty easy to break off. When I've done this in the lab, I've usually used a Kerrison. And you can try again that tomorrow, and you'll get a chance to see the vertebral artery proximally and distally, and find that zone of injury, really identify where it is, and then get proximal and distal control over it. This is something that all of us as spine surgeons should be able to do. Whether you're a neurosurgery trained, orthopedic surgery trained, you should be able to expose the vert if you injure it and get proximal and distal control. Okay? Whether you use clamps or vessel loops, I think that's a little bit of dealer's choice. I'm sure everybody's got their flavor or their preference. But again, find those transverse processes and unroof the foramen. This is a still picture I took from one of Dan Rue's talks. I think this talk is on the CSRS website, on the YouTube channel. Plug for the YouTube channel. Everybody go, subscribe, check it out. But again, using these vessel loops to get proximal and distal control over it. The next step, whether you repair or ligate, this is where if I were to have a vertebral artery injury in my current institution, I know I'm calling our vascular neurosurgeons for help. And that's because we've already had this conversation. We have actively said, if we get a vertebral artery injury, who are we going to call? What are we going to do? You're not running around trying to figure out if this is vascular neurosurgery, vascular surgery, is it IR? You want to have your plan in place ahead of time. And who you work with is going to vary, I think, right? Based on where you work and what the relationships you are. But build those relationships ahead of time. I do all my cases on a flat top OSI table in the OR to have a radiolucent bed available just in case we have an issue, so that we could do an intraoperative angiogram if needed. And then again, you're looking for contralateral circulation and you're looking for posterior circulation as well. And then the question about repair or ligate, again, I'm sure we're going to have some difference of opinions. Our conversation with our vascular neurosurgeons typically is that if it's a dominant vertebral artery or if we're concerned about posterior circulation, we're going to attempt a repair on it. Whether those repairs actually stay open or not, that's a whole other discussion. How long do you put them on aspirin afterwards? That's another discussion. Do you stent them? We have a couple of our IR folks who are a little more gung-ho about stenting these, but then do those stents really stay open? There's a lot of unknowns there, and we certainly don't have any literature to support, I think, a clear, singular direction for repair or ligate. So in conclusion, I think pre-op planning is really critical. Look at the imaging, look at the imaging, look at the imaging. Be prepared as a team. Know where your equipment is. Know where you have, whether it be vessel loops or aneurysm clips. Know who the team is that you're going to contact for help if you run into this trouble. And work out in your mind what those clear steps are, A, B, C, and D, to get hemostasis, proximal and distal control, and then a plan in place to figure out whether you're going to try to repair these or ligate these. For me, in my practice, that means calling for help and asking for good advice and good consultation with our vascular team. And then practice, I said today, but tomorrow. In the lab tomorrow, really practice exposing the vertebral artery. Do it on both sides, left and right. Go around and look in the room for all the different specimens. I guarantee you're going to find variances in the lab that you might not have expected from specimen to specimen. So, thank you.